Hello and welcome to episode number 4 of the Joey Mattina podcast. Today we are joined by dentist Dr. Jon Marashi. Hey John, great to have you with us. Jon, Dr. Marashi has a very successful dentistry practice in Beverly Hills. He performs cosmetic dentistry and some incredible work, and we share some clients, and we thought it'd be very interesting to discuss some of the case studies that we've had over the years and also learn more about what Jon does and how it blends in with chiropractic care, because it's been so valuable. And I've learned so much, Jon, from talking with you about the cases and learning about the mouth and how it affects the body. So welcome. Thanks for coming. Thanks for being on.
Thanks for having me today, Joey, and I'm excited to be here and share a thing or two.
Amazing. Doc, I like to just usually start out with just a brief background on you and how you got into dentistry in the first place.
You know, it's been an interesting path of travel because from a very young age, I knew that there were only two things that I wanted to do in this life of mine, and it was going to be either a dentist or professional skateboarder. That's it. And fortunately, the way that the cards fell, I ended up being professional dentist and amateur skateboarder as opposed to the opposite. But I'm turning 50 this year, and I've been skateboarding for 38 years, the entire time, and so I kind of feel like I won the lottery that I get to do both still.
Amazing. And how long have you had your practice now in Beverly Hills? Or it's
Well,
not
I've
Beverly
been
Hills.
in,
You're in. Go ahead.
yeah, I'm in Brentwood, yeah, right next door.
Brentwood. Yeah, not
Yeah,
Beverly Hills. I said that earlier. Brentwood.
yeah. Um, I moved to Southern California back in 2004. So, I mean, I'm rolling up on 20 years now as a Cali boy. And, it's home. I was always California dreaming. And, and I think I'm like 14 or 15 years now in Los Angeles. So, yeah,
Mm.
it's been the bulk of my time here for sure.
And in terms of the things that you do at your practice, can you give us an overview of some of I said cosmetic dentistry. I don't know if that's entirely accurate. I'm sure there's other things other than just cosmetics. So what do you guys do there?
Yeah, I mean, the bulk of what I do is, in fact, cosmetic dentistry, and it's a bit of a funny misnomer because, dentistry is a human invention, right? Like we invented this stuff, and nowhere in the playbook for dentistry did it say fix someone's tooth but make it look ugly. The idea was to restore form and function, and form has to do with the aesthetic appearance of something. So, um, cosmetic dentistry has come to mean for most people of just really more of an enhancement of form. But the goal in dentistry, like, I mean, to me, it's kind of a no-brainer. Like, duh, of course you're supposed to make it look nice, and I enjoy doing that for people. And when people ask me what I do, what I really do is I give people confidence, and their confidence
Mm.
comes through their smile. So it's really exciting to be able to touch both of those. But going back to the form and the functional aspect of how the mechanics of the teeth work together as a team and how it relates to the entire musculoskeletal system is a very it's a complex situation, and there's most dentists don't do enough of it or have enough of an understanding because they're pretty advanced concepts, and that's where there's obviously a massive crossover between our two disciplines. And um, for anyone who's actually listening to my gas bag right now, a lot of the things that I learned about the interconnection between dentistry and what a talented chiropractor will do was from myself being a patient. So
Hmm.
Joey saved my life.
Yeah, no, you're doing great, man. Um, yeah, in terms of sort of how you started doing these, you say that these are more advanced techniques. I know that you go so into detail. It's unlike any other dentist I've spoken with before. And because what you're doing is you're taking, as you said, you're correcting form and function, but also form. But what is it with the function? Because we see a lot of, a lot of our overlap has been with neck tightness, jaw tightness, uh, even headaches. And a lot of times we'll do a conservative, plan of care, and things won't resolve, and then we go and start looking in the mouth, and that's where we've learned a lot from you. What
Yeah.
what's kind of your clinical workup? If let's say we send a patient, say, listen, we've tried for weeks, or it could be someone that's not from us as well. What does your workup look like when they come in and say, for instance, I'm grinding at night, I've got intractable sort of jaw tension and neck pain?
Yeah. So when patients come over for you, I mean, the beauty of it is that a lot of the screening has been done for me. I know they're coming in with some sort of musculoskeletal issue that probably has a dental etiology. So, do you want me to go down that path as opposed to someone where I have no knowledge and I'm trying to figure it out?
Yeah, let's start down the first path.
Okay. So, when someone comes in and they've seen Dr. Joey and they say, look, I have, you know, pain in my jaw, and they've been doing treatments, and they get like a temporary relief, but it comes right back. What that tells me is that there is probably some sort of underlying dental alignment issue. And dental alignment issues come in two buckets. The first bucket is orthodontic. And the best way to distill orthodontic is just simply where are the teeth positioned in your mouth? What's the relationship between the top and the bottom teeth? And just because they're straight teeth doesn't necessarily mean that they fit together really well. You could have really crooked teeth and they could fit together perfectly and you could be asymptomatic. So orthodontic just
Mm,
means tooth position, but whether you come in with straight teeth or crooked teeth, that's not necessarily the determinant of, oh, you got a problem. The
hmm
second bucket is orthognathic, and orthognathic refers to what is the relationship between your top jaw and your bottom jaw, because the mouth is a very fluid moving system. And if you think about it, your bottom jaw, when you're talking, when you're laughing, when you're chewing, it can move in any direction you want it to go. You can push it forward, you can swing it right, you can swing it left, you can move it up and down, you can even retract your jaw, you can pull it backwards slightly. It's in and from a chiropractic perspective, this is really interesting. It's the only fully movable joint in the entire body. Every
hmm
other joint in your whole body, you know, you might be able to, rotate it or you might be able to bend it, but the
hmm
jaw can rotate and translate both. And there's no other joint in
hmm
the whole body that can do that. So it's a very complex mechanism.
Yeah. And what are in terms of facial structure, do you see, do a lot of people have orthognathic issues that become or create problems either acutely or down the road
Yeah,
that you
and some
see?
people you can just look at them, and without even
Yeah.
looking in their mouth, they could know. So I'll give you some really easy to envision examples.
Yeah.
There are conditions called overbite and underbite. And so the best way to think of an overbite is like our favorite cartoon character, Bart Simpson. And if you see him from the profile, it looks like his top jaw is way forward and his bottom jaw is massively retruded. And that creates a skeletal imbalance. And some people think it, looks, funny or it looks weird, but it's because the bottom jaw typically is too small to fit up against the top jaw. The opposite of that is an underbite. And, think of comedian Jay Leno, for example, and you see him from the profile, and his bottom jaw and his chin is much farther forward relative to the rest of his face. And so when he closes his teeth together, or anyone rather who has an underbite, what you'll see is that the bottom teeth are usually biting in front of the top teeth, and most people will bite in the opposite direction. So generally, if I see someone with a significant overbite or a significant underbite, I know that the mechanism is off, and there's a higher probability that there's going to be some sort of skeletal issue causing a dental issue, which in turn causes muscle issues. The other thing you can look for is facial asymmetries in the lower jaw. So
Mm,
if you look, generally speaking, things are somewhat symmetrical on the face. And if you look at the position of where someone's chin is, if the physical position of the chin is not centered and it's like way over to the right or way over to the left, well, then what happens is if your jaw is way over to your right side, then the jawbone on the right side ends up being shorter and the jawbone on the left side ends up being longer. And
You're
if you think
talking
about
literally
that,
the bone's longer.
yeah, it's physically
That's how
longer. I'm
it.
talking about in the horizontal direction, not in the
Yeah.
vertical. And so as a result, it pulls the chin over to one side. So
hmm
imagine if you shift your entire jaw over because of that skeletal asymmetry, the teeth are never going to fit together correctly. And so what happens is when the teeth don't fit together correctly and the jaw is not lined up correctly, that changes how the jaw joint functions. And this is sort of this is like the root cause of where all the pain and the discomfort usually ends up. Because as I mentioned earlier, the TMJ, the temporomandibular joint, is a joint that can rotate and can translate. So what happens is when the teeth are biting together trying to find home, because the teeth are out of alignment, because the jaw's out of alignment, you close together and now it's torquing on your jaw joint. It's like if someone
hmm
was like, rotating your wrist and twisting it, you'd feel all this weird tension in your elbow, right? But imagine your masseter muscles, which are your jaw muscles, those are the ones the primary for closure. And these suckers can generate upwards of 900 pounds per square inch. It's crazy. So imagine you got
hmm
these huge bite force closing you down and it's torquing on it. Like it's going to start creating inflammation and pain in the area. And then the other issue for
hmm
the anatomy geeks listening to us is that inside of your cheeks you have these muscles called pterygoids, and you have internal and external pterygoids. And when your teeth don't line up properly, those pterygoids will oftentimes be in a state of contraction. And it's like if you ever went to the gym and you start doing bicep curls and you get to the last one where you're holding at a 90 degree and the trainer says, oh, hold it for like, 20 seconds or whatever. And then, your bicep is just burning, right? But imagine if your jaw was stuck in that contraction all the time. You're going to build up all this lactic acid. The muscle's going to become really tender, maybe even a little fibrotic. And I think that that's where there's like a lot of like physical therapists and chiropractors, like for those who know how to glove up and go in the mouth and they squeeze those muscles and the patient's ready to start crying because it's so horribly painful. And you can go in and do the muscle work and loosen it up, but the underlying cause has not been addressed. So that's why they say, oh, I got some relief. But then, within a day or two, they're right back to the pain again.
hmm I was just about to ask you what are some of the most common symptoms you see from these types of patients when they have a is this called a deviation? What's the technical term for that when one jaw is shorter?
Oh, I mean, that's all it is, just an asymmetric mandible.
Okay.
Yeah.
Asymmetric mandible. So when patients have these, what are some of the common symptoms they come in complaining of?
Yeah, the common symptoms that they'll come in first is they'll always describe it as like jaw pain, and then they'll point. And what I'm looking for is where are they pointing to? And usually they're going to point to one of two places. They'll either point to the corner of their jaw, which tells me, that's masseteric in nature and it's a muscular problem. But if they
Mm.
point right in front of their eardrum, then that's your TMJ and that's a joint related problem. And so, sometimes if they're just, kind of waving haphazardly, then I'll touch these areas myself and say, is it this one or this one? And, if it's both, it's like, oh, now we really got a problem.
And if you see that and it's more muscular in nature, is that generally good news, bad news, or you don't really know yet?
Well, we don't know yet until I actually, depend. So there's like a pecking order of things that you want to start checking through to see if you need to investigate farther, right? And that's not much different than with the layers of the onions that you guys are peeling back. And so when I'm doing my evaluation process, you know I could I could have a patient sitting in front of me that has perfect orthodontic alignment, and I could check the relationship between the upper jaw and the bottom jaw, the position of the condyles, and everything checks out perfect, but they still have pain and discomfort. And so at that time, I have to determine, is this muscular in nature, which generally speaking is probably more of like a grinding clenching issue.
Mm.
or is there something going on in their TMJ? If it's with the TMJ, there's ways to palpate and feel if there's something called crepitus. It's kind of like a crunchy sound going through, um, or if there's popping and clicking noises. But you never know for sure unless you've actually had an MRI of the area, because
Mm-hmm.
the TMJ, in between the glenoid fossa and the on the maxilla and the head of the condyle on the mandible, there's a piece of cartilage. It's a disc. And that acts as your shock absorber. So these two bones aren't grinding against each other.
Mm-hmm.
So the MRI will typically show us what's going on with that piece of cartilage, and it actually gets damaged a lot easier than one would think. And you'll see, they call it a biconcave disc because it's those what do they call those blue discs that you stand on in PT to try to balance yourself? Is that
Bosu
a
ball.
Bosu? No, but not the ball. It's the one that looks like a frisbee that's
Uh,
filled with air.
yep.
And but the shape of it, instead of being plump, it's scooped out on both sides. That's what the TMJ
Mm-hmm.
disc is like,
Mm-hmm.
and that can actually get mushed over time if there are uh, alignment issues in that area. And generally that's irreparable. So
Mm.
that's when bad things are happening. Or you can actually see osseous or bone changes in the area where, like, the head of the condyle starts to wear down flat, and that's a problem because you could actually have someone who's got good teeth structure. But imagine if you shortened one side of your jaw on the vertical component, then the whole thing kind of shifts up on one side, and it puts pain up in the joint, and the bite is unstable. So, you need to have imaging, and usually between an MRI and a CT, you can get the information you need to figure that out.
And so not much can be done for those discs once they're damaged. Do you ever get in there or put anything inside that joint?
So it depends on what's going on, and once again, what the root cause is. So if you have someone that has a stable occlusion, doesn't have orthodontic issues, and they just have a hot joint, first thing you're going to do is probably start with something conservative like a splint therapy, and that's like a type of bite guard. But let's just say that the MRI shows, oh my God, this joint space has like broken down particles in it and things like that. A very skilled oral surgeon can actually do a joint arthrocentesis. And, that's basically, they go in there and they flush it out with saline, and they can get rid of like little inflammatory particles on there, and help the area get some relief. If the joint space can become stable, which is usually achievable by either, you know, moving the teeth or moving the jaw around somehow, then over time, a damaged TMJ, there's evidence in the literature that says you can reform a fibrotic capsule in there. They call it a pseudo joint.
Mm.
And that actually kind of puts more um, reinforcement in that area. So you end up having less of an issue or less pain and discomfort.
Mm-hmm. Mm-hmm. I like this concept. How prevalent it is to have this asymmetrical jaw? Do most people have an asymmetry of some kind?
No, most people are centered or centered well enough. I mean, this is definitely, I wish I had a statistic for you. I should have been better
Mm.
prepared. I apologize to look that up and tell you, what they think the incidence of that is in the general population. But, um, and we're talking about more extreme examples, of course.
Yeah.
The stuff that we see that's like when I say a lot of people, I'm talking about like even coming through my office, I'll see people that, oh gosh, probably greater than 50% of the people that come in just, for normal routine dental care that have no perception of pain or discomfort in the area, but they have tooth issues that are causing other issues, and they're on their way. And a lot of that will come from teeth grinding and clenching, And the root causes of that, sometimes it's habit, sometimes it's stress, but oftentimes we see the teeth grinding and clenching is because the teeth aren't fitting together correctly. So then we have
Yeah.
to look and say, okay, well, why is it done? Why are they not fitting together correctly? Now, in the case where you have asymmetric jaws, and we call that an orthognathic issue, there are jaw surgeries that can be redone to reposition the jaws and even them out and balance it out. But generally, when that gets done, the teeth don't fit together anymore because the teeth were fitting
Mm.
together. The semblance of that bite was based on the incorrect jaw position. So it's very rare that you can get an orthodontic procedure done, a jaw surgery, and not require some sort of adjunctive orthodontic treatment to move the teeth so they can fit together in the final resting place.
Is that standard procedure? Because I've had a few patients over the years that have come in and they'd had jaw surgeries to correct that bite.
Mm-hmm.
Is it standard procedure to also have the orthodontic stuff done as well, or sometimes is it kind of getting overlooked?
No, I mean, maybe in years past, but in with contemporary approaches today, oftentimes there's what's called pre-surgical orthodontics, where they're actually moving the top teeth and bottom teeth independent of how they fit together right now, based on what the final position should be. So when they do the jaw surgery, the teeth are almost perfectly lined up, and now the jaws are in the right place, and then there's minor orthodontic finishing to get them to lock into place.
Wow, and they do that beforehand. So there must be some kind of three-dimensional technology scanners. How do they do that?
Yeah, so technology has totally changed how we can do these things. And it's not even just for these complicated cases. I mean, it's even just for doing one tooth, because sometimes fetal sensitivities are so, like, the story of the princess and the pea, right? And a lot of people have bites like that. One tooth is off, and they're just in agony, because one tooth, was done incorrectly, or didn't get adjusted right. How technology blends into this is that there are software programs, like after you've taken a CT scan, that can virtually move the teeth and the jaws to the ideal position. And then there's software from an orthodontic perspective that can actually show you, okay, here are the required mechanics and movements to go from A to B. And then they can actually build, like, orthodontic brackets and aligners and things like that to make sure the teeth end up in that spot. And when they're there, then there are actually what we call surgical guides. These are like pilot holes and templates that will fit on the teeth. So when they've basically released, when they've done releasing incisions through the bone, and they put these things on the teeth, it moves the jaw to the exact position where it's supposed to be. So when they put in fixation
Mm.
screws on the bone, like, it's not just like, oh, well, this looks good. This is like, 4 millimeters to the left and 8 millimeters to the right. It's actually, that's how it used to be. It was a little bit of a guess, right? You're like, oh, well, we think it should go here. And now they can really do it with great precision.
Wow, that's really cool. When you do these, when you say that the teeth aren't lining up properly, how do you go down and make them fit properly? You're filing them down. What's the process there?
So if it's a non-orthognathic issue, and so we've eliminated the jaw possibility, and we're like, no, we think that this is tooth related. Then what I have to determine is, in order to get this person comfortable and for their occlusion means the lock and key fit of the bite, or the teeth, in order to get this right, do I need to move the teeth out of the way, or can I do something to modify the topography of the tooth, the hills and valleys on it, so it'll fit better? Sometimes it's one, sometimes it's the other, sometimes it's a combination of both. Most of the time, the stuff that comes through my door are things where I can actually modify tooth shape in order to get it to fit correctly. And so it can be additive or subtractive in nature. Okay. Subtractive means, let's just pick on one tooth. Someone comes in, and I find that there's actually a trigger point because one tooth is off. And it could be off for a whole bunch of reasons, right? Maybe it just grew in that way and it's always been that way, but it's been this way for so long that, now it's, pain is set in. It could be that the tooth moved or shifted, or it could be that the tooth had dental work, and that's very, very common problem that I see is that a dentist does like a filling or a crown or a veneer, and there's a thickness to it, right? And it impacts the bite, and if it's not adjusted so it fits in seamlessly with everything else, it's like having like you ever had like a rock stuck in your shoe, and you know you think you're good for like the first block, right? Like you're walking down the street and then you're like, oh, this isn't so great, and you kind of shifting your toes around a little trying to get the thing to the outside, and then 2 blocks later you're sitting on the curb taking your shoe off and shaking the thing out, and you're like, why didn't I do that 2 blocks ago, right? You put
Hmm.
your shoe back on, you're like, huh, I got relief. But guess what? The bottom of your foot still hurts, and so, these are things that we see in dentistry. And so if it was a dental restoration that was engineered too thick, then, I have to identify where that is and adjust it accordingly. But sometimes you'll get someone who's come in and had a mouthful of dental work, and you got some of them are too thick, and then you got some of them that aren't even touching. So that's like chewing on air. And a good way to think of the bite, it's kind of like a three-legged bar stool. And Joey, do you ever sit on a three-legged bar stool where where one of the legs, or was a little shorter,
Oh
or
yeah,
or maybe they're all three different lengths? Like, what's it feel like when you're sitting on it?
you're doing that wobble. You're trying to find the.
Exactly, right? And then you hope that like if you're a dentist, you hope that he gets up and goes to the men's room and you do a swapperoo on the stools, and then he comes back and he's like, "Hey, what happened to mine? I don't know, dentist. Like, I'm sitting here the whole time." So, if you think about that with the bite, and imagine if you take the weight off one of the legs, right? Because now you made it too short, the weight doesn't disappear on that leg, it just goes somewhere else. So like if you're light in your bite, say on the left side, then that pressure's got to go somewhere. It'll go forward of that space or backwards of that space, or maybe to the other side of your mouth, and that makes the imbalance even worse. So if that
Hmm.
was the issue, that it was too light, you're not going to shave the rest of them down to meet it. What you're going to do is you're going to say, identify, hey, we got a space here. So what we need to do is actually take dental material and bond it to the tooth to build that up, to reinforce it and put support back in. It's just like, if two of the three legs, or if one of the three legs on the bar stool is short, just, like get a longer replacement in, and now the thing is stable. You don't have to chop the other two down.
Is this more common in the molars or certain types of teeth, or can it be anywhere?
It can be anywhere, but it's more common in the back than the front, because the back has more surface area, going across the chewing surfaces.
Sure.
And that's where the bulk of your chewing is done. And so statistically, you're going to see far more dental restorations being done there too, in the form of, fillings or inlays or crowns or things of that nature.
What's your opinion on Botox for the jaw?
Um, I think Botox is a fantastic adjunct. And I'll give you an example. If you get someone who comes in and you look at the shape of their head, right? And if the jaw, where the masseters are, is wider than where the temples of the head are, then that person is like an Olympic lifter in their mouth. They are biting and clenching constantly, and that's building up that massive musculature. So, you know, it's not going to work if you say, hey, I think you grind your teeth. You should really just try to stop doing that. That's how the person is wired. That's what they do. So, giving them Botox in the area and decreasing the bite force and just giving some time for those muscles to atrophy is definitely going to help them, because now you're making them weaker in that area. And that's what you want. You're trying to decrease bite force. But at the same time, you also want to look for the root cause. And so if it's just this is, some sort of uh, habit that they have, then this is going to help. Habit meaning that, grinding and clenching. Um, but if there's an underlying orthodontic or orthognathic issue, the Botox is just going to be a Band-Aid because they're still going to keep doing it. And then they're going to be stuck, Botoxing for life in order to, try to mitigate some of the effects of it.
So let's just say, as an example, somebody comes in and you see that they've got this, they're definitely clenching. They've got extremely hypertrophied masseters. Would you start them potentially with that before you went in and started looking at the alignment? Because will that not affect the alignment of the teeth potentially?
No, the Botoxing them is going to have zero effect on the alignment of the teeth because what
Ah,
you're going after with the Botox is the muscle. And if the muscle is has hypertrophy on it, then you're treating it, like you're treating it because it's big and you're trying to make it smaller and you're trying to decrease the bite force. But if
mm,
that muscle is heavily inflamed in the area, you need to figure out why is this inflamed and eliminate rather the source of that problem. So the Botox, you're not just injecting into an inflamed area and you're just kind of masking the effects of an underlying problem.
I see. Yeah, I guess in my mind, I'm thinking more, if one side were more tense than the other, and I guess then it would be shifting the potentially alignment of the jaw.
Mhm.
To, if you had one side that was spastic per se.
Yeah, so if
Um,
you had that and it was just someone who is just like you, just a grinder and a clencher, no underlying orthodontic and orthognathic issue, then that could be a great way to, to help treat them.
got you. Yeah, I've found that to be very helpful for a lot of cases over the years. Just you know, but you hear sometimes you want to keep updated. Like what are all the news? There's always new information coming out, and I would just like to stay on top of it. So it's good to hear that for someone that spends so much time with people's jaws, that's a beneficial treatment method. Um, the You said that sort of these techniques you do, they're not often done in a lot of other practices, and I've known you for a number of years now, and there's dentists, and then I feel like there's you. I mean, not to put anybody else down, but you go above and beyond in so many ways. And these little, you say you a lot of the things you see are from previous repairs potentially that you go in, and then it's like you just make them perfect. How did you get into doing that kind of work? Did you start out? Did you have mentors that taught you these things in the beginning?
Oh, 100%. I mean, I think our paths of travel aren't even that different. That we sought out people who were just exceptional, and I mean, look at Dennis Colonel. Like we're both so fortunate to have this guy, taking care of us, and certainly for you having him as a mentor. And I kind of recognized early on in my career that I didn't want to be the neighborhood dentist, and there was a higher calling in terms of uh, what I wanted to do and how I wanted to do it, and I realized if I was going to get there, and I wanted to get there, faster than maybe people before me had, I needed to surround myself with incredible coaches and mentors. And I mean, that's the best way to get cuts to the front of the line. It's a philosophy of mine, and I tell young dentists all the time. Find if you can be the dumbest person in the room, you actually stand a chance at learning something. Um, if you're the smartest person in the room, then you probably have a glass ceiling over what you're actually going to know. So that was really pivotal, at such an early point in my career, was getting myself in the room with people who were exceptional at, you know, doing cosmetic dentistry, doing full mouth reconstructions, doing this advanced type of jaw work, and understanding, the connection to the rest of the body with it. And what happens is, like anything else, like when you're early on and you're first learning it, it's not like you're good at it. You might understand it, but the fact that you've started it earlier and you got good guidance with it, you know, by the time you're a short few years in, you've probably seen and done and understand more than, people who are getting ready to retire. And then by the time, you're 5, 10 years in, it's like you've packed this huge snowball of experience, and not all the cases that you do in the beginning go perfect or smooth, and you know, sometimes things go sideways too. I mean, that's just part of the learning process, right? But the idea is that you're getting more reps and you're learning how to do it, and that allows you to do more of it and advance your skill and your and the kind of cases that you're going to take on, probably a lot more quickly and at an advanced level than you would have done otherwise.
Yeah. And that's why, it's part of, I know a huge part of why that you're so successful in what you do. You love what you do. And that kind of leads me into, you got this practice in Brentwood. And it would be great to go over a case study or two that we've sort of co-done over the years, or one that you've done with Dennis, perhaps. And just so people can understand sort of what the process would be, specifics, if you don't mind, we don't have to use any names or anything like that.
Yeah.
But because I remember one in particular, a singer,
Hmm.
with is that a good case to go over?
That's a great one. So that's actually the
Okay,
one I was thinking of.
beautiful. So can you just kind of walk us through? And I was around, but that was more you and Dennis. So I would love to know how that whole case went.
Well, it was very interesting because I remember Dennis called me and he said, "Hey, John, I have a very well-known singer that I've been taking care of for a number of years, and he's always complaining about tightness in his neck, and it's on the back of his neck, behind his ears, and for you anatomy geeks, it's the posterior auricular area, and if you think about kind of right behind your ears, and then start moving your hands down your neck, and it kind of connects um, to where your trapezius muscles are, that whole area, so many people carry a lot of pain and tension, and they don't realize that the underlying cause of it can actually stem from the bite. And Dennis had done multiple treatments and adjustments for this gentleman, and the guy would feel better when he left, but he never got resolved. And you know one of the things I've really liked about working with you guys over the years, and I remember you told me, God knows how many years ago it was, Joe, but I remember you told me, you said, look, if I haven't figured out what it is and fixed it within a few appointments, it's something else. And it really stood out to me about, like, wow, these guys really understand that you just can't keep doing the same thing to someone indefinitely, that there's got to be some other problem happening. And so, when Dennis called me and he said, "Hey, here's what's going on and here's the areas that I'm treating." And he said, "I'm wondering if it's something else and maybe there's a dental component, and can you check this guy's bite?" And I said, "Sure, send him over. Let me take a look at it." And so, um, the guy came over, and I like working with checklists. I think that it's easy to look at someone and you know, physically they look good, but you don't know what's going on the inside, right? And so, like if a plane is going to take off in the air, it doesn't matter what that plane looks like on the outside. They got this really strict checklist that they got to go through before this thing has clearance to take off. And you hope to goodness that they don't find anything, right? Because you want to go up in the air. But if they do, thank goodness that that checklist was there, because they're like, all right, well, we can fix it, or this plane is grounded, one of the two, and now your life was just saved. And I work with a checklist as well, where I don't want to make any assumptions about what is or is not going on in this person's mouth and in their jaw structure, and the associated complex. So I'll go through my checklist, and you just have to be as unbiased as possible. And if I turn up negative with everything, then the only thing I can say is nice to meet you today. And we can rule this out, that you don't have a dental component associated with it. But sure enough, in this particular case, what we found is that this person had an imbalance in their bite, which was because of dental work that had been done. And oftentimes what happens is, like let's say you're, you know, 40 years old ish, or maybe even a little bit older, then chances are you've been having dental work done for at least 20 years at this point, right? Because, most people don't have a ton of dental work done. Um, as a kid going up till 20, unless it's just like, some basic fillings or whatever from eating too much junk food as a kid. So here's my point. Imagine you have someone who spends their life on the road. And oftentimes, as you and I know, you know, artists, entertainers, actors, singers, you name it, because of the demands of their schedule, sometimes most of their care that they get for taking care of themselves is more sort of reactionary care and just, trying to put the wheels back on the bus like after they crash the bus, as opposed to maintenance care. So you'll see someone where their mouth has like a series of patch jobs and they met different dentists of different skill levels over a long period of time. And so there's been this degradation of the whole system. And once I saw that, I said, hey, wait a second, this probably, is what the cause is. And, after I did all of my measurements, I was like, oh, wait a second. I don't even have to go and rebuild this whole guy. I just need to realign it properly. And that actually came from not replacing the existing dental work, but just reshaping it to get the proper lock and key fit back in his bite.
Mm.
And so that's what was done. And it was a single appointment. And I think it took me about an hour and a half to do all of it. And you know, my I was really happy for him because he was able to feel immediately how much more comfortable he was. But the proof of the pudding is like, all right, well, how's this guy going to be like a week from now, a month from now, and a year from now? And I think this is what are we several years out, on this, and he's doing pretty good.
Yeah, amazing. How did so on visual inspection you could tell, oh, there's a lot going on here. And so already you're thinking, okay, this is going to be interesting. And then you take these measurements.
Mhm.
And are these measurements done with a type of computer?
So there are different ways to do it. There's what I would call the analog way, and there's the digital way. And both of them serve different purposes, and I use them based on how sometimes like I'll lay on the table and you'll grab my ankles and you can feel what's going on, and there's no digital that's going to give you this data. You've just your hands have such an acuity of where things are supposed to be. So a really good dentist can actually feel things similar to that, and that's what I would call analog. Where I'm moving the jaw and I'm feeling certain things and looking where it is. And so that's what was done in this case. And, for anyone listening who's ever had like a filling or a crown done, there's this paper that you bite on and you tap and you don't really know where it's going and kind of leaves a mess. So there's actually a technique that can be done that's highly, highly accurate that uses contrasting colors that will show us not only where the teeth are touching and where they're not touching, but with how much surface area and with how much intensity. And
Hmm.
those are and so it's kind of like learning how to read footprints in the snow or who shot who from where and where the bullet shells are, and putting this whole thing back together. And you know, when I started doing this, the digital stuff really wasn't around. So, I've gotten really good at it. But now there are actually digital bite sensors where you can put them
Hmm.
in the person's mouth and it will measure two things. It'll measure bite force and timing. And timing is interesting because it'll tell you when you close your teeth together what hits first, second, third. And so sometimes the one that hits first is not actually the one that hits the hardest and that's causing it. So, for people learning, I mean, I would recommend learn how to be proficient at both because it's like if you only got one trick in your or one tool in your tool belt, you're going to have limited options for applying it.
Wow, that seems, I mean, you have so many different angles that you're looking at timing, you're looking at like you said, so you have so many different things that now are at our fingertips for helping people with these types of issues. It's pretty incredible. I remember when I first learned about what you did a few years ago, maybe more, I was, I never even considered that. And that case that you just described was one of the first ones where I remember, I was learning, continuously learning, but back then I remember thinking, oh, I had an aha moment of how important tooth alignment could be. And that was a real eye opener for me.
Well, I mean, I'm eternally grateful that you guys have drawn that connection because I think that between what you do and what I do, not just us as clinicians and as individuals, but between our respective professions, there's a big knowledge gap that's there to the detriment of our patients. And if more clinicians from dentistry and from chiropractic medicine had an understanding of what's out there, the interrelationship between the two, and what the other person brings to the table, I think there's just a lot of patients that could find better relief. I'll give you one example. You know, for Okay, I have to say this first, right? Because I rarely meet a dentist that purposely tries to do a crappy job for somebody, right? I mean, like, come on, we're all healers. We got into this for, very altruistic reasons, right? Like, we're trying to truly help people. And so, um, but, for those who, with good intention, don't have the know-how and the experience and the training, one of the default um, treatment modalities for patients come in is just here's a bite guard. And a bite guard is a fantastic treatment modality, but it has limitations. And I want you to think of it like this: it only works when you wear it. So imagine if you have a problem where its underlying cause is not being addressed. All right, so you put this bite guard in, and how many hours a night do you think the person is sleeping for to begin with? I mean, we know 8 is a miracle. So at best, a third of their day. So this person has 16 plus hours per day where the underlying cause is causing havoc and pain and discomfort in their mouth, and all I got is this little piece of plastic. So that's why I think it's so dang important to understanding, what's going on with this. And, because one of the things we haven't talked about yet is, you've talked about sending people my way, but, how about the flip side of that where I'm sending people your way and I'm like, look, like, I can take care of these variables here, but the sequela from the bite being off, which causes other muscle issues that I can't treat or do any palliative relief for because it's not my area of training, right? With like back and neck. Or if I find someone where I'm like, hey, you know what, you're totally clear through here, because a lot of patients do come in, they're like, well, I must be grinding, so I have these neck pains and this and that. And I'm like, no, you're actually fine from a dental perspective. You need to go and see a chiropractor and get this looked at. And what's been so great working with you guys is your ability to figure out and discern, okay, is this muscular an issue? Is this an alignment issue? Or is there some really bad orthopedic stuff going on, that we need to get like another type of doctor involved with this?
Yeah, I love that point because when you're doing your differential diagnoses, I just think it's so important just to reiterate this. If you have a patient with neck pain and it's not going away, or jaw, and you're treating them with whatever modalities you use, don't forget about what's going on inside the mouth, and not just the pterygoids. The tooth alignment can be a game changer if you just put your mind there. So, even asking some questions about past dental work, I think, is so important to keep in here for any chiropractors or physical therapists, dealing with patients that have these types of things. So, keep that in mind. I just want to reiterate that it's been huge. Um, let's see. You just touched on. There was one thing I wanted to ask you about that. I just escaped my mind for a second. Let me think if I can come up with it. I did want to ask you about if you had any other case studies. Is there another one slightly different that you have? If not, that's okay. Just something slightly different. Do you have anything in mind?
Yeah, so it's funny. I got another one from you guys recently. Female, and she's a movie producer that you guys sent over. Said, "Hey, John, can you check her bite for me?" And this is interesting because it's a real testament that you don't judge the book by the cover. Like when you get someone come in, who's young enough and nice enough looking and has nice enough looking teeth, it would be very easy to make an assumption like you're fine, like this is something else, or you're making a bigger deal out of this than what it really is. And, I've just, I've done this enough now, to put the blinders on for these things and stay true to the checklist. And, as I was going through this, I was like, hey, wait a second, you know what? Like, The teeth look good. The alignment of the teeth look good. The orthognathic position looks really good, but she still has symptoms that, I think there's a dental component to this, and it's causing other issues, like in the back of the head and the neck. And like you guys said earlier, it's like, what came first, the chicken or the egg, right? So this was one
Hmm.
where I said, you know what? I don't think there's anything for me to do here yet, but I want to get an MRI and see what's going on. And so um, we just got the results back actually this past week, and I spoke with the patient. And I said, listen, I said, I have some good news and some bad news for you. The good news is that I don't think you need anything that I'm going to be able to do. So, like, you're not going to end up with a mouthful of dental work. But um, on your jawbone, your condyle, which is the part that pivots up in your TMJ, is flattened, and that piece of cartilage is actually stuck in front of it. The cartilage is physically dislocated. I mean, like an analogy would be like, imagine, if the cartilage in your knee popped out the side and got stuck there. Like, how would it feel when you bend your knee every time? Imagine if that was your jaw joint, and your
Huh.
jaw's moving all the time. So, I've referred her to, can I give him some props? Richard Jacobson, because he's an orthodontic and orthognathic specialist in Los Angeles, and just has a tremendous know-how. And so, this patient's going to go see Rick and figure out, does she need to have an orthognathic procedure to correct this? Or is this one where there can be some sort of orthodontic realignment that could actually help pop that cartilage back into place? Um,
Hmm.
and but I'm telling you, like, these problems in dentistry are missed so many times because people don't dig deep enough, or or they go to the de facto, like, just try to relax, like, just don't grind your teeth. It's like saying don't be stressed. Like, come on, this is life, folks. And and if there or here's a bite guard, but once again, understanding that there are limitations. That bite guard is nothing more than a band-aid for the amount of time that they're actually wearing it for. You can't wear one of these things 24/7.
I get that sense a lot with folks that have bite guards. I just intuitively sometimes I think this just doesn't seem like it doesn't seem like it's helping necessarily because it's not adjusting the proper thing. And so those are always, whenever I hear someone says, "Oh yeah, I wear a bite guard," I like to dig deeper into that and where they got it, why. So that another thing that I think is super important. Actually, just remembered too, sort of along that line, what I wanted to ask before, which was, let's say someone's coming in and, because a lot of people you ask say, do you clench your jaw? And they say, well, I don't know, because a lot of times it's done while we're sleeping. And let's say, for instance, you don't know, you haven't been, accurately diagnosed with that yet. Can you, if I had someone say, hey, John, this patient's got this, I send him to you after a few visits and say, can you let me know, can you tell if they are jaw clenchers by looking at the surface of their teeth, or are there things that you can see that would show you that or tell you
Oh,
that?
absolutely. Yeah. I mean, like, the two low-hanging fruit that that really, any clinician can develop an eye for, they don't even have to be a dentist, is what's going on with the jaw musculature. Do they have masseter and temporalis muscles that are overdeveloped in size? You know, are they soft and supple, or are they like, just like feel like rocks? And oftentimes I'll just have them clenched down, and you watch these things pop out of the side of their head, or even watch, when you start watching people talk and you see the masters just popping out like bulging biceps. I know I always use that example, but it's really accurate. Or upon palpation, you touch these things and they're so tender, because of the lactic acid buildup in it. So that's with the muscle side. And with the teeth side, if you understand what a tooth is actually supposed to look like versus one that has, enamel damage from the effects of teeth grinding and teeth clenching, the low hanging fruit is look at it, and if the edges are all chipped up, then chances are there's something going on. Your molars and your bicuspids, which are the back teeth, and they have these hills and valleys in them. And if they, instead of looking like they have these really, kind of like mountain range looking teeth, if they look shallow and flat or more like an ice skating rink or like, a couple of nickels rubbing over each other, then this person's going to town with it. And the other thing is oftentimes there's a lot of people that just don't know they're doing it. I mean, I've had more patients than you can imagine. They're like, I don't grind my teeth. And then, like you sort of plant that seed and they come back, they're like, holy shit, I grind my teeth all the time. And they just didn't have a conscious awareness of it.
Yeah, exactly. You may not know that you're doing it. I just had another one and I lost it. I'll get it in a second here. Jaw clenching.
You're asking me about can you see the effects of either musculature or effects on the teeth to know whether someone is a grinder and a clencher?
Right. Yeah. So you've got the visual, you can look at the muscles, and then you can also just, in terms of what you're looking at with the surface enamel of the teeth. Oh, I got it again. All right. Tooth, this may be pretty obvious, but let's just say, how important is proper tooth hygiene? Like, for instance, I'm thinking flossing, that let's just say you're not a good flosser and you get some decay or, erosion, I guess, to the enamel. Can that have a large impact on how teeth line up if you don't take proper care of your teeth?
Yes, but that's probably more of an extreme case because in order for a tooth cavity to have an effect on alignment and, with the things that we're talking about here, I mean, literally the tooth had to have like imploded. And so, like collapsed so bad that it's no longer, there's not enough of a supporting structure to support the bite properly. And, and generally speaking, you know, if you lose support just on one tooth, you got to have, like you do have others helping support it, but like when you have someone like maybe there's more of an extreme example, but like maybe someone who is using meth, for example, because that stuff is so harsh on the teeth. It usually comes from because if it's smoked, it creates this horrible acidity, and then oftentimes there's eating after it, and that puts in carbs and there's sugar in this environment, and the teeth actually start rotting at the gum line. And then they just start breaking off, and then you start losing like chunks of teeth in large segments, and now the whole bite starts collapsing. So that's probably more of an extreme example, though.
Yeah. I just had a few more questions, John, just on some other little topics here. I'm curious. I have a lot of patients coming recently asking me, say, oh, I'm starting to see a holistic dentist. Is that just in terms of like the types of things they're using in the office? What is that? What's a holistic dentist?
My mom told me if I didn't have anything nice to say, don't say it at all. Um, uh, jokes aside, is that holistic dentistry, has become this area of dentistry that describes people who are trying to take sort of these natural approaches and, in my humble opinion, okay, well, let me start with saying this first. There is no specialty called holistic dentistry. There is no formal training program endorsed by, to my knowledge, endorsed by the American Dental Association that says, here you could become an orthodontist or you could become a holistic dentist. Like that doesn't exist. It's this sort of moniker, and it's been used to try to steer clients, away from old techniques in dentistry that people aren't even really doing today anyway. It was like, don't use the amalgam restorations because of concern about, mercury content. I mean, like that stuff doesn't, most contemporary dentists don't use these antiquated materials anymore. The bulk of mainstream dentistry, in first world countries are using, modern ceramics and bonding materials and so forth. And so I've I've seen a few of these patients come in, and they talk about like I have to be metal free or fluoride free or this and that, and then like I look at the recommendations of the treatment plan after they kind of get their head pumped full of all this stuff from the dentist, and I'm like, sir, ma'am, this treatment plan is what any dentist anywhere would have given you without, branding themselves as a holistic dentist. So um, I think I don't take issue with it in terms of the treatment that's being offered because there's no secret treatment or advanced training skills that is being offered that you couldn't get from someone who is a good dentist anywhere. I think it's just being marketed to attract a certain type of patient, or maybe create a little bit of fear mongering or give the appearance they have some special training that someone else
I
doesn't
see.
have. And so I'm not really on that bandwagon, as a moniker, because once again, like I call myself a cosmetic dentist, but there's no official cosmetic dentistry um, uh, specialty from the American Dental Association or what have you. It just describes that what I do is very appearance driven.
Hmm.
So if I'm going to throw shade at the holistic dentist, maybe I'll throw a little shade on myself at the same time. but um, but I guess the reason, the real thing is just that I think that sometimes it gets pushed that that there's something special going on about what they're doing that everyone else isn't doing, and unless you're practicing kind of prehistoric dentistry, you're probably not doing anything um, that uh, that would be frowned upon, by anyone.
So sounds to me like it's like it got LAified. It's an LA segment of dentistry that you
Yeah,
may not
that's a
find.
great way of putting it. Yeah, that's
Okay.
a yeah.
Thank you for clearing that up because I'd been hearing that and I thought, is there some special technique? And I didn't really know. So I'm glad I asked you that. Um, what I'm curious, in your Brentwood area, do you have relationships with other chiropractors or physical therapists on a regular basis and have this kind of interaction or collaboration?
My philosophy in working with other practitioners is a bit unique because I don't believe in working with second best. That's why I have one orthodontist office that I work with, and that's why I have only one chiropractic office that I work with, and it's you guys. And I've been very blessed because um, patients have entrusted me, with their care, and people come from all around the world, to for me to help them. And what I realized is that oftentimes the things that people need are outside of this, narrow scope of things that I do, right? And so I'm not going to be, like I'm never going to be able to do what you do. I just need to know enough about it so I can understand and recognize when they would need you and then send them to you. And what I have found is that um, there is an abundant patient population globally that wants to have the best, and they don't expect it to be just from one provider, and they're actually very appreciative, of me, that I know what my limitations are, especially in dentistry, right? Like I don't try to do a root canal on someone. I have an endodontist that I work with for that, and they appreciate that. Hey, what, let me stick with the part that I'm really good at, and I'm going to get you with the other person that is the best at this. And I believe that to be the same, when I refer to a physician, a dermatologist, a plastic surgeon, an internist, an orthopedic surgeon, and absolutely to my chiropractic team.
Love that. Yeah. Well, thank you for saying that about us. We love working with you. The best. I had a question in terms of uh, do you ever give patients any exercises per se? So if they have large masses, is that one of those things that you consider sort of out of your realm, or is that a typical dental practice to say, hey, try putting a hot compress if you got a very tight jaw, or is that more something just post surgical
No, no, no,
or
no. I
post
mean,
operation?
because if someone comes in and they're in acute pain, there are palliative things that can be done, right? Just like when someone comes in, with something hot, that you got to treat. And so, you know, There are times for ice, there are times for hot compresses, there are times for a medication regimen as well. And so, you're looking at big picture to determine, do they need, emergency palliative care right now? Or has this person just been miserable for a long time and it's chronic, and we have time on our side to start going after what the underlying cause is? And sometimes it's both, right? Like, you gotta stop the problem at hand just to, because they're so miserable, but then you can't just leave it at that. You got to go back and get the underlying cause.
Yeah. John, we've covered quite a bit today. I want to just ask you, you're responsible for many of the most well-known smiles in the world, and you just do an incredible job. What advice, because I consider you a mentor of mine, we come in and we have good conversations. You always have amazing advice for me and have really sparked me and motivated me in many ways, including showing me books to read and things like that. And, what advice would you have to anyone wanting to become a dentist, maybe in school right now, as they embark on their journeys?
Oh, well, thank you for the kind words, and I appreciate that so much. And the feeling is mutual, Joey. Absolutely. My advice for, anyone, whether they're at the student level or earlier in their career, or, or even in a mature place of their career, anyone who's looking to up their game, I think there are three things that can be done that are going to move the needle in the most impactful way. Number one, know your outcome. Okay. You know, if if you just start driving, aimlessly, odds of you getting to somewhere, a destination, in the most linear fashion, odds are against you. But if you know where you want to go and you got a roadmap of getting yourself there, now you have a plan and a strategy. Hope is not a strategy. That's I've heard this being said before, and I truly believe in it. So you got to know your outcome. Okay. Number two, which we've already talked about, is coaches and mentors. And I think what a lot of clinicians think that the only people that they can learn from is another dentist or another chiropractor. And that's only one small piece of the puzzle. Um, in my personal and professional life, I have had coaches and mentors the whole way through, ranging from people in dentistry, people in business, you know, people who are really good at public speaking, life coaches, people from all different walks of life that were exceptional at what they do, that had skills that I felt that I needed to develop and get some level of mastery over, to become a better version of myself. The third thing is, and this is not a sexy recipe, man, it really isn't, is discipline and consistency. And, when you're at the student level, I mean, if you're not prepared to roll up your sleeves and eat a crap sandwich for a long time, I got some news for you. You're going to be really disappointed because this stuff is hard. But if you're willing to do the work, it's like this. Like, could you imagine, like if someone comes in and they're totally out of shape, because they didn't work out, and they eat junk food all the time, and they're like, well, I went to the gym one day and dieted one day and it didn't work. Like, what are you talking about? Like, of course it takes more than a day. It's going to take years to turn this ship around. And, and it's no different in any other aspect of your life. So, in your clinical career, right? There are dues that you have to pay to learn how to do things, right? And if you are in your, in your practice, right? Like, it's not just being a good clinician, but there are all these skills that you need to have to understand, how does a business work and how do I grow this thing? And, so, um, and it takes time and discipline, and it doesn't happen overnight. But if you're doing your business push-ups, every day, and you're doing your clinical push-ups every day, day in, day out, over time, you're going to build these skills. And, I always say, like, you know, uh, uh, um, one is that, the guy who's talking right now, I wasn't born this guy. This is like I became this guy over time. I was built by design. I was very intentional with from who I used to be and who I wanted to become, and it was an evolution and a process. And my business coach, this guy named Keith Cunningham, he's actually phenomenal. He has this saying. He goes, "You know what hell on earth would be? In the future, meeting the person that you could have become." And
I
it's
like
like,
that.
wow. I mean, it kind of hits you. Um, so I love talking about this stuff. It excites me, and I'm at the point in my career now too where it's really fun to share these things that I've learned along the way to hopefully try to help and inspire as many people as possible.
Yeah, I was just thinking too. I was having visions of the future where we do just an entire talk just on that stuff because I love talking about that stuff with you. You're an inspired guy and disciplined, and it's just I can tell it fires you up. It's really cool. And actually, just for listeners, are you? I know that you've spoken, you've or been a guest. Perhaps was it on Tony Robbins? Do you do that actively, or are you still doing
I am.
sort of
In
that kind of?
fact, yeah, I'm going to be speaking. So, um, Tony Robbins does this program called Business Mastery, and it's a really great program, by the way, just to give them a prop. But January 11th, I'm speaking at it again, and there's I should give a shout out to David Meerman Scott. He's one of the regulars on the program, and he talks about marketing concepts, related to your business. And I was actually one of his students, and it was really exciting to just not know anything about this and learn it and apply it. And um, I had some success with it, and for all these years later, I've been able to go back and share my experiences with the audience.
Amazing. We'll look out for that. January 11th, Doctor will be doing the business mastery with Tony in Tony's group. Jon, it's been a pleasure. Thank you so much for making the time to speak with everybody here today. Speak with me. It's always a pleasure. Um, is there anything else that we haven't talked about that you would like anyone to know about? Misconceptions in dentistry, anything at all that you have a message, a message to give?
Actually, I do, but it's not dentistry, but it's relevant
Okay,
for our talk. So,
great.
um, I came in as a patient for you guys because my neck was so bad from tilting it down and looking at people's mouths all day to the point where I was getting these muscle spasms and C5, C6 issues. And my wife, who is an emergency room doctor, was very reticent. And, like, I don't want you to see a chiropractor because, they're going to crack your neck and you're going to end up in a C spine collar. And, one of the downsides of being an ER doc is when you're seeing someone, it's usually because something went wrong. No one goes to the ER to show the doc how good their cholesterol is that day. And so, I understood her concern, and I said, well, look, I'm going to go see these guys anyway because, I know how good they are, and I feel like I've tried a few things and nothing's working. And it was my first time ever seeing a chiropractor, by the way, was coming to see you guys. And you know, from the minute that I was in there, I mean, it couldn't have been farther, my experience from snap, crackle, pop, but understanding there was this whole, you know, maybe not very well understood amongst the public about what it is that you guys do and how you look at the body, from a very comprehensive standpoint, between the muscle and the alignment and one of the biggest takeaways I've got from you guys is oftentimes where it hurts is not where the source of the pain is. And so, you know, the pitfall for me is I just go back to work and wreck myself. So I'm like an annuity for you guys. I have to keep coming back in, on the frequent flyer plan to undo all the havoc that I cause on myself. But it's really just it's amazing as you guys have helped my body improve over time that I've gone from chronic and I'm in pain to, hey, just help keep me straight and comfortable. And so, this is a super long-winded answer, but a lot of people don't realize
I like
like
it.
going to the chiropractor is not always because something is jacked up, but it can just be just to help you maintain where you need to be so you don't end up in a bad place.
Absolutely. Yeah. I mean, I remember, you had that hot poker feeling going down the back of your neck into your shoulder blade, and that was consistent for a long time. But you've been very consistent, and I mean, it's like a new body. I mean, not just the neck, the legs, and so this stuff works. Tissue does reversibly, get better, and you don't have to live in pain. So this stuff, it's like maintenance, man. Just like you said before, consistency, discipline. That goes for a lot of things in life. Dr. Marashi, where can people find you? You're active on social media. You're on Instagram. What's your handle?
Yeah, my handle is at Dr. Jon Marashi, so DrJonMarashi.
He's also online, drmarashi.com. And anything else? I think we're good, John. I think we're set. Thank you so much for joining us tonight.
Thank you for having me. It's been an honor and a privilege, Joey. And I think I see you next Wednesday, too.
Sounds good.